So we'll start the next lecture of the series by GCRI team, and Dr. Mayur has prepared well for the drug called Tapentadol and Dextropropoxyphene. Dr. Bhavna will moderate, and Dr. Mayur is a third-year junior resident of palliative medicine MD in Department of Palliative Medicine, GCRI. And Dr. Bhavna was there in the last lecture also. She is Associate Professor at Department of Pain and Palliative Medicine at GCRI.
Thank you. Hello, good morning to everyone. I am Dr. Mayur taking a lecture on 2 opioid medication. This is slide note 4. Slide note 4. Taking to lecture on 2 opioid medication, Tapentadol and Dextropropoxyphene. First, Tapentadol. Tapentadol is a novel centrally acting opioid analgesic. It is a synthetic opioid analgesic with the chemical class of phenyl-3, which one of the 4 chemical class of opioid medications. IUPAC name of Tapentadol is 3,1R, 2R, 3-dimethylamino, 1-ethyl, 2-methyl-propyl phenol hydrochloride. It is a non-racemic molecule. The molecular formula of Tapentadol is C14H23NO. Molecular mass of Tapentadol is 221.344 gram mole raised to -1. Tapentadol was invented at the German pharmaceutical company Grünenthal in the late 1980s, led by Helmut Buschmann. In 2003, Grünenthal partnered with 2 Johnson & Johnson subsidiaries and Ortho McNeil Pharmaceutical to develop and market Tapentadol. Johnson & Johnson had exclusive right to sell the drugs in US, Canada, and Japan, while Grünenthal retained rights elsewhere. In 2008, Tapentadol received FDA approval. In 2009, it was classified by Drug Enforcement Administration as a Schedule 2 drug and entered the US market. Schedule 2 drugs belong to narcotics drugs and psychotropic substances. In India, Central Drug Standard Control Organization approved Tapentadol immediate release preparation for moderate to severe acute pain in April 2011 and extended release preparation for severe acute pain in December 2013. Pharmacodynamics of Tapentadol. Mechanism of action of Tapentadol is not exactly understood, but it going to take a going to action on 2 receptors. So first is it is centrally acting analgesics with 2 mechanisms of action. First is mu opioid receptor agonist and second is norepinephrine reuptake inhibitors. It binds to mu opioid receptor selectively with more than or equal to 10-fold affinity compared with the delta and kappa opioid receptors. The affinity of Tapentadol for mu opioid receptor is 4-fold lower than that of morphine. Noradrenaline reuptake inhibitors increase the level of noradrenaline, which enhance the action of the descending pain inhibitory pathway through activation of inhibitory alpha-2 receptors. This dual mechanism of action contributes to its opioid sparing effects. Opioid sparing effects means the reduced requirement of the dose of opioid medication is less, as is also affected at a norepinephrine reuptake level. So opioid analgesics must be requirement in lowest concentration. Tapentadol is also weak serotonin reuptake inhibitors, but this action does not contribute to its analgesic effect. Tapentadol is equivalent to much higher dose of per oral morphine than tramadol. Thus, practical purpose, tapentadol is considered as a step 3 strong opioid analgesics. Tapentadol is 3 to 4 times less potent than morphine. This dual mechanism of action of tapentadol showing agonist at a mu opioid receptors as well as the inhibit the reuptake of noradrenaline at the presynaptic terminal. Tapentadol is like a tramadol is a synthetic opioid medication, but some differences between them underlined here. Tapentadol is a more potent than tramadol. It is like approx 3 times more potent than tramadol. So better analgesia with tapentadol. Tapentadol showing weak inhibition of serotonin reuptake. So side effect wise, it is good than tramadol. There is tapentadol is a active drug and tramadol is a pro drug. So early onset of action with tapentadol. So we can got analgesia within short duration, and tapentadol does not showing any in lack of cytochrome 450 interaction. So minimal risk of drug interaction with tapentadol. Pharmacokinetics of tapentadol. Tapentadol is rapidly absorbed. Oral bioavailability after single dose and administration is 32% due to extensive first pass metabolism. One set of action is 30 minutes to 1 hour. Time to peak plasma concentration is 1 hour and 15 minutes in for immediate release preparation and 3 to 6 hours in modified extended release preparations. Protein binding is 20%. Volume distribution 540 liters. Half-life of immediate release preparation is 4 hours and for modified release is 5 to 6 hours. And duration of action of immediate release is 4 to 6 hours and for modified release is up to 12 hours. Metabolism and excretion. Tapentadol is extensively metabolized to inactive metabolites via conjugation. Tapentadol or glucuronide is the major metabolite. It is also metabolized to N-dis-methyl tapentadol by CYP2C9 and CYP2C19 and to hydroxytapentadol by CYP2D6, which are further metabolized by conjugation. CYP enzyme do not play a major role in metabolism. None of the metabolites contribute to its analgesic action as all the metabolites are inactive. Tapentadol does not inhibit or induce the activity of any cytochrome isoforms. Tapentadol is metabolite that excreted almost exclusively via kidney from urine. Drug interaction. Tapentadol is metabolized by hepatic enzyme CYP2C9, CYP2C19 and CYP2D6. So it innately has interaction with drug that enhance or repress the activity or expression of one of more this enzyme. Tapentadol is contraindicated in patients who are receiving MAO inhibitors or who have taken them within last 14 days due to potential additive effects on norepinephrine levels, which may result in adverse cardiovascular events as well as adrenergic storm. Tapentadol should be used with caution in patients who are taking one or more anticholinergic drugs, as this combination may result in urine retentions. which can result in serious renal damage and considered a medical emergency. Patient receiving other opioids, general anesthetics, phenothiazines, sedative hypnotics, or other CNS depressant like alcohol along with tapentadol may have additional CNS depression that may manifest as a respiratory depression, hypotension, or profound sedation. Combination with SSRI or SNRIs may lead to, or serotonin receptor agonist may lead to potentially lethal serotonin syndrome. Caution while prescribing tapentadol is moderate hepatic impairment, epilepsy, or seizure activity. Switching from the other opioid, tapentadol causes low-grade opioid withdrawal. So PRN doses of original opioid may counter this. Abrupt discontinuation of tapentadol may result in symptom of opioid withdrawal. So tapering gradually recommended. It has potential for abuse and addiction, hypovolemia, adrenal insufficiency, acute pancreatitis, delirium tremens, head injury, and elevated intracranial pressure. Contraindication of tapentadol is hypersensitivity, significant respiratory depression, acute or severe asthma, hypercavia in unmonitored setting or in absence of resuscitative equipment, gastrointestinal obstruction, including suspected paralytic ileus, co-administration with MAO inhibitors or use within 14 days, severe CNS depression, severe renal and hepatic impairment, perioperative pain, pregnancy and breastfeeding woman. Adverse effect most commonly seen is nausea, vomiting, dizziness, drowsiness, and headache, somnolence. Less commonly found of various nervous system like fatigue and anxiety, insomnia, irritability, vertigo, chills, depression, and confusions. And psychiatric disorder like hallucination, and panic attacks. Gastrointestinal disorder like diarrhea, constipation, pruritus, xerostomia, fatigue, anorexia, dyspepsia, cardiac disorder like hypertension, dermatologic pruritus, hyperhidrosis, skin rash, endocrine hot flashes, genitourinary erectile dysfunction and UTI, respiratory upper respiratory tract infection as well as dyspnea. Uses: moderate to severe acute pain, post-procedural pain, chronic musculoskeletal pain. It is also specifically indicated for controlling the pain of diabetic neuropathy when the around-the-clock opioid medication is required. Tapentadol use should be reserved when the inpatient who are poor metabolizer of cytochrome enzyme, when other opioids or step 1 analgesics medication does not go into pain relief. Doses of tapentadol, it is available in various strength. Immediate release strength are available in 50 milligram, 75 milligram, and 100 milligram. Extended release tablet available in 100 milligram, 150 milligram, 200 milligram, and 250 milligram strength. Acute, moderate to severe pain, immediate release tablet dose is 50 to 100 milligram per orally, 4 to 6 hours, and increase gradually over up to 150 milligram 4 times a day or 6 hourly, not extended to 600 milligram per day. In chronic severe pain, modified release tablet, extended release tablet 100 to 250 milligram per orally every 12 hourly, and starting dose for this is 50 milligram BD for 12 hourly and not exceed to 500 milligram per day. Dose modification in renal impairment. If creatine clearance is greater than 30 ml per minute, no dose adjustment required. If creatine clearance is less than 30 ml per minute, it is contraindicated. In hepatic impairment, mild impairment, child Cook score in class 1, no dose adjustment requirement. In moderate impairment, class B of child Cook score, immediate release tablet, initial dose 50 milligram 8 hourly, maximum 150 milligram over day, and extended release tablet, initial dose 50 milligram every 24 hourly, once a day, and maximum is 100 milligram per day. In severe impairment, it is contraindicated. After long-term use, abrupt withdrawal of tapentadol may result in symptom of opioid withdrawal. Thus, tapering is gradually. With less than 12 months of use, withdrawal symptoms were mild or absent. Tapentadol has a potential for abuse and addiction. Monitoring parameters in patient of going to take a tapentadol, see the relief of pain, mental status, vitals, bowel function, urine drug testing recommended. Prior to initiation and rechecking should be considered at least yearly. Includes control prescription medication in illicit drugs of abuse. Evaluate benefit risk of opioid therapy within 1 to 4 weeks of initiation, and with the dose increment, reevaluate every 3 months during therapy or more frequently in patient at increased risk of overdose or opioid use disorder. Sign and symptom of misuse, abuse, or addiction. Sign and symptom of hypogonadism and hypoadrenalism. The second drug of dextropropoxyphene. Dextropropoxyphene is a synthetic weak opioid. It is a chemical group of diphenyl heptones. The chemical formula of dextropropoxyphene is C22H29NO2. IUPAC name of dextropropoxyphene is 1S2R1-benzyl-3-dimethylamino methyl 1-phenyl propyl propionate. Molecular mass of dextropropoxyphene is 339.479 gram mole raised to 1. It is intended to treat mild pain and also antitussive and local anesthetic effect. Patented in 1955 and manufactured by Eli Lilly and Company. It is an optical isomer of levopropoxyphene. The drug has been taken off the market in Europe and thus the US due to concern of fetal overdoses and heart arrhythmias. On 23rd May 2013, the Indian government suspended the manufacture, sale, and distribution of the drug under Section 26A of the 1940 Drugs and Cosmetic Act. Pharmacodynamics. Dextropropoxyphene acts as a mu-opioid receptor agonist. It is also act as a potent non-competitive alpha-3 beta-4 neuronal nicotinic acetylcholine receptor antagonist. Nicotinic acetylcholine receptors have a 5 subunit of alpha, beta, gamma, gamma, epsilon, and delta. These 5 subunits ligand between alpha-3 and beta-4 where dextropropoxyphene act. It is also weak serotonin reuptake inhibitor, chemically related to methadone, but is similar to codeine action. Propoxyphene, both levo and dextro, act as a weak agonist at OP1, OP2, and OP3 opiate receptors within the central nervous system. Propoxyphene primary affects OP3 receptors, which are coupled with G protein receptors and function as a modulators, both positive and negative, of synaptic transmission via G proteins that activate effector proteins. Binding of the opiate stimulates the exchange of GTP for GDP, the G protein complex, as the effector system is adenylyl cyclase and the CMP located at the inner surface of the plasma membrane. Opioid decrease intracellular CMP by inhibiting adenylate cyclase. Subsequently, the release of nociceptive neurotransmitters such as substance P, GABA, dopamine, acetylcholine, and noradrenaline is inhibited. Propoxyphene also inhibits the release of vasopressin, somatostatin, insulin, and glucagon. Opioid close N-type voltage operated calcium channels and the open potassium channels. This result in hyperpolarization and reduce the neuronal excitability. Pharmacokinetics of dextropropoxyphene is after oral administration, it goes first pass metabolism and has a bioavailability between 30 to 70%. One set of action is 20 to 30 minutes. Time to peak plasma consent is 1 to 2 hours. After therapeutic dose, protein binding is 80%. Volume distribution is 16 liter per kg. Plasma half-life is 6 to 12 hours. Clearance is 2.6 liter per minute. The major route of metabolism is cytochrome CYP3A4 mediated and demethylation of propoxyphene, which is excreted by the kidneys. In 48 hours, approximately 20 to 25% of the administered dose of propoxyphene excreted via urine, most of which is free or conjugated propoxyphene. Dextropropoxyphene is metabolized by hepatic enzyme CYP3A4, so innately has interaction with drugs that enhance or repress the activity or expression of this enzyme. The risk of severity of adverse effect can be increased when the dextropropoxyphene is combined with a benzodiazepine, and as well as risk of or severity of adverse effect can be increased when the cannabidiol is combined with the dextropropoxyphene and used with caution in alcoholics. Caution while prescribing dextropropoxyphene is hepatic impairment, in renal impairment. It is not recommended as a metabolic product excreted by kidney. A pregnancy, in category means no any study conducted of dextropropoxyphene use in pregnancy in both human or animal. It is excretion in breast milk is unknown, so use with caution in breastfeeding women, use with caution in elderly. Contraindication: patient allergic to dextropropoxyphene or paracetamol. It is available in two forms, plain or with the combination in paracetamol. So patient allergic to any of this molecule, it is contraindicated for allergy. Alcoholic patient who are prone to suicide, anxiety, panic or addiction, chronic respiratory distress, porphyria, pregnancy, use with or within 2 weeks of discontinuing MAO inhibitor treatment. Side effect is headache, mood fluctuations, hallucinations, dependence, skin rashes, constipation, faintness, sleepiness, nausea, vomiting. There are more serious potential problems, including seizure, cardiac dysrhythmias, and even heart block, if dextropropoxyphene is purposefully or accidentally taken in excessive dose. Toxicity and overdose of dextropropoxyphene may lead to various systemic effects. Excessive opioid receptor stimulation is responsible for the CNS depression, respiratory depression, and aspiration pneumonia, meiosis, and gastrointestinal effects seen in propoxyphene poisoning. Also account for mood or thought altering effects in the presence of amphetamine. And propoxyphene overdose increase the CNS stimulation and cause fatal convulsive seizures. In addition, both propoxyphene in its metabolite norpropoxyphene have local anesthetic effect as concentration about 10 times those necessary for opioid effects. Norpropoxyphene is more potent local anesthetic than propoxyphene, and they are both more potent than lignocaine. Local anesthetic activity appeared to be responsible for arrhythmia and cardiovascular depression seen in propoxyphene poisoning. This direct cardiac effect include decreased heart rate, decreased contractility, and decreased electrical conductivity. This effect appeared to be due to their local anesthetic activity and are not reversed by naloxone. Widening of the QRS complex appeared to be a result of quinidine-like effect of propoxyphene, and sodium bicarbonate therapy appears to have a positive direct effect on the QRS dysarrhythmias. Seizures may result from either opioid or local anesthetic effect. Pulmonary edema may result from direct pulmonary toxicity, neurogenic, anoxic effects, and cardiovascular depression. Balance disorder is possible with risk of fall from standing height. It is available in two forms, plain dextropropoxyphene as well as combination with acetaminophen. Available strength of dextropropoxyphene is 65 milligrams. It should be taken start from 1 to 2 OD2, maximum 3 to 4 times a day. Monitoring parameters while prescribing in patient of dextropropoxyphene, relief of pain, vitals, monitor sign of overdose, evaluate benefit risk of opioid therapy within 1 to 4 weeks of initiation and with dose increases. Reevaluate every 3 months during therapy or more frequently in patient risk of overdose or opioid use disorder. Monitor blood gases, pH, electrolyte levels, and ECG. Reason for withdrawal of dextropropoxyphene from the market: overdose related death including suicide, extent of fatal cell poisoning with dextropropoxyphene or acetaminophen combination in some countries, death following overdose due to toxic effect of high level of dextropropoxyphene on respiration and cardiac conduction. Concern regarding utility as an analgesic, as some resources stated that there is no evidence that dextropropoxyphene in combination with acetaminophen is more effective than acetaminophen alone. Impact on electrocardiophysiological activity: both 600 and 900 milligram doses of propoxyphene were associated with significant QTc prolongation and that were greater than that of recommended in guidelines. In addition, a dose-dependent prolongation of PR and QRS interval was observed in the study. Evidence for effectiveness of dextropropoxyphene as an analgesic: some reviews have found dextropropoxyphene as well as combination of dextropropoxyphene acetaminophen 650 to be comparable to tramadol in efficacy for nociceptive pain. Current guideline: as per the notification in the Gazette of India dated April 13, 2017 by the Ministry of Family Welfare, use of dextropropoxyphene has been permitted for use in cancer treatment or cancer pain treatment only, and Micron Pharmaceutical get permission to market this management of cancer pain only. Dextropropoxyphene use in India: Dextropropoxyphene has been a commonly prescribed analgesic in India and has been used for management of pain associated with acute and chronic condition. Easy availability of this medication even in the village has made it a commonly prescribed medicine. Dextropropoxyphene is the least expensive drug, step 2 opioids in the WHO ladder approach for cancer pain management. As equivalent dose of tramadol is likely to cost much more than what dextropropoxyphene costs. Has been quoted that 100 milligram tramadol 4 times a day will cost twice the daily income that defines the poverty line. The cost advantage associated with dextropropoxyphene was supplemented by its easy availability. Most of the other opioids, such as morphine, are stringently regulated and are not widely available. Implication of dextropropoxyphene as a common drug associated with suicide in some countries like UK cannot be used as an argument to veto this drug from Indian market. Dextropropoxyphene did not even figure in this list means of suicide in India in recent publication. Thank you.
Thank you, Mayur, for giving an overview of dextropropoxyphene tapentadol. Arun, do you want Dr. Bhavna?
There are no questions, ma'am, but if anyone has any question, I think they can just unmute and ask. Okay, questions are coming as we speak. So for the GCRI team, I'll just read the question, okay? Do we need to fill DD12? I don't know what that is. Form for prescription of both the medicines, that is tapentadol and dextropropoxyphene. Question for GCRI team.
I can't
even
see
I don't know what is DD12.
What is DD12?
Hello.
Yes, Dr. Preeti, go ahead, please.
Actually, we have not used dextropropoxyphene anywhere, but company people is saying there is no need of any license. So I think there is no need of DD2.
Can I answer this? DD12 form is a form which usually we prescribe for narcotic medication, morphine, fentanyl, to purchase from the outside market, that is from the pharmaceutical shops. So for tapentadol and for dextropropoxyphene, we don't need DD12 form. So we can write in your prescription as such, and you can get from the market.
Ma'am, can anyone share this dextropropoxyphene?
Pardon?
We are not using. Does anyone using?
No,
is it used at your institute, ma'am?
No, we don't use it routinely, but it is available. It is scarcely available. Actually, it was vanished from the market. It was the cheapest analgesic possible for all over country. It was used, but because of various reasons, which government has decided once that it should be stopped, and then with lot of advocacy, again it has come into the market. And as Mayur in the last slide said, that it is now available for cancer pain management. It is still, if you write in your prescription, many a times people will not get it, these medication. But tapentadol, which is a fancy second line opioid drug for pain management, it is expensive and it is available all over country. So if somebody wants to get tapentadol, they will get tapentadol on prescription, but they will not get dextropropoxyphene.
Yes, we have tapentadol, but we do not have. Company people are saying, if you prescribe, we will directly deliver it to the patient, or we'll give it to you, and it will be available for patient. But still, we are afraid of using tapentadol. I mean dextropropoxyphene, so we have not started using it.
And so company people claim that it is cheaper. It's not cheaper. It's equivalent to tramadol.
I can see Nandini. Nandini, you want to add something in these two drugs? or anyone has any comments? Arun, are there any questions?
Yes, thank you, ma'am. One more question, please. So, Mary Abraham, she wants to know the brand name for dextropropoxyphene.
I think
Subinol.
The
Subinol.
only brand available.
Vidya,
Okay.
do you?
There was
Vidya,
one slide also.
Vidya, you want
No,
to?
no, ma'am. I don't have dextropropoxyphene. I have tapentadol. So in fact, I was eager to know if it is available and who's using it.
Actually, it is available nowadays, but it is again. It is if you will write something, it will be very difficult if you write in the prescription to get on in the market. But tapentadol they get immediately. So this is the actually this is all pharmaceuticals the thing, but it is available. And this was the analgesics which people were using a lot in the olden days.
Yes, madam, that is true.
Hmm.
We used it when in way back, but of late for this purpose, I haven't used it.
So what I miss, like after hearing last lecture of tramadol and tapentadol and dextropropoxyphene, although dextropropoxyphene is used, miss, like we were using very frequently in olden days, because it is now it's not available scarcely. I think what we can suggest that with the Dr. Mayur's lecture today and with the complications and the I think side effects, we should say side effects with associated with these medication, I think it is always better that if cancer pain patient, especially if they are in moderate to severe pain, starting low dose opioids. What do you think? I think I miss, like I'm concluding this. I can see Dr. I can't say Dr. Nandini here. Do you want to add something? Anyone wants to add something in this lecture, because there is so much to say, those who are using these medication? Okay,
Shall I
Dr.
say something?
Yeah, Dr. Preeti, please go ahead.
Yeah, I think none of we have used dextropropoxyphene, and company people is saying, and now ban is released, and it can be used for the cancer pain management. The drug is very cheap and there is no need of license. So I think we should start using under monitoring the way we have started using methadone. So we will be able to know how drug is working. This is my
Definitely.
suggestion.
So, Dr. Tejaswara, may I know the efficacy of tapentadol compared to Calpol-T? Mayur, you want to answer? Calpol-T is paracetamol, kya, doctor? Calpol is paracetamol.
Paracetamol and tramadol.
Paracetamol and tramadol.
So I think this is Mayur, you want to answer this?
Yes, ma'am. I think tapentadol is a much more efficacious than this combination of tramadol and paracetamol. Is tapentadol is 3 to 4 times much efficacious than the tramadol.
Okay, you got the answer, or you want to say something? Tejaswara. Dr. Baisin is asking what is the status. So I said that 2015 it was banned, but in 2017 it was again approved to use for cancer pain management. But it is still scarcely available. When you will write it, rarely people will find in the market. So it is Officially, it should be available, but you know, when people will not use what pharmaceutical company will manufacture, they will stop manufacturing. They similarly, if methadone we will not stop using, we are not using a lot in all over country. Even methadone person, Rusan Pharmaceutical, they keep asking me that should we stop manufacturing methadone because people are not using. So methadone is a good analgesic. I think we will have a lecture methadone. I think next lecture, and people should start using methadone. Dr. Aruna says that she is using tapentadol. Yes, it is highly potent. It is a good analgesic, but it is associated with a lot of side effects and it's very expensive for our patients. So, very careful. Dr. Jennifer, you want to add something in these two medications? Your experience?
Thank you, ma'am. In the past, we have used dextropropoxyphene. The brand name here was Proxivon, a combination of paracetamol with dextropropoxyphene. It was very good as an analgesic, but after it was banned and we have stopped, but it has come back, but we've not gone back to using it. Tapentadol, we have both immediate release and controlled release preparations, which we use. The only thing between tapentadol and tramadol is tapentadol is much more costlier, so that is a problem. Calpol T is a combination drug, slightly smaller doses of tramadol. So if we want to use tramadol in good doses, it's better tramadol or tapentadol than a combination drug. Thank you.
Thank you, I think this is absolutely right. That olden days we were using, but it is again, it's because it vanished from the market, so people are not in a habit of now writing. And we are not exploring the tramadol because of the cost. I think better and combination drug. We don't know what is working and what. So better it is if we use in a formulation of tramadol and paracetamol or tapentadol and paracetamol. Anyone wants to add anything? Arun, you want to add anything? Arun?
No, ma'am, I'm good. Thank you very much.
Dr. Bhavna? आपका mic muted है, Dr. Bhavna.
Yes, ma'am. I think everything is covered. And as we are not using, we don't have any matter to share experience. But some shared experience, and thanks everyone for sharing.
Dr. Raji, I can see Dr. Raji. You want to add something, Dr. Raji? Your experience. Dr. Raji? I'm sorry, whichever name I can see on the screen, I am asking. So, any resident who want to add something? I can see Dr. Reena also. Dr. Reena? Dr. Reena George?
No, just to echo the point, yes, we were using Proxivon safely earlier and have stopped, and it was stopped some years back. My plea to the residents would be calculate the monthly cost of tramadol and tapentadol when you make your choice. And if the patient can tolerate tramadol, which we've used very well for many years, then do not make tapentadol your first line. Calculate the monthly cost, look at the patient's vulnerability, and then take a call.
Thank you very much, Dr. Reena. Thank you. Thanks a lot. To anyone, Neetu and someone wants to add something? Any resident? Senior residents?
Good morning, ma'am. Ma'am, Meenakshi here. I just wanted to add one point, which I've noticed while using tramadol and tapentadol. The side effect profile, especially the vomiting and the constipation, which we see with tramadol, is lesser when we use tapentadol. And the neuropathic pain alleviation is also marginally better with tapentadol. This is what I've noticed in a few cases that I've used.
So I think you should do a study on this, because there is hardly any study on comparison with tapentadol and tramadol.
Yes, ma'am. Just the cost is the limiting factor. So I've used it only in patients who could actually afford it.
I know
So
it.
that's why I don't have many numbers to quote, but this is what I've noticed. I just thought I'll share that, ma'am. Thank you.
Yes.
Dr. Sushma, I think if you just use domperidone for the first 3 days and use bisacodyl, which we do with morphine anyway, the additional cost of those side effect controlling drugs is probably still less than the cumulative cost of tapentadol. And for neuropathic pain, we used to add a little bit of mirtazapine, which helps sleep, appetite, and many things. So maybe we should look at the cost of the entire package rather than the standalone drug without controlling its side effects.
I agree, Dr. Reena. I agree absolutely. I understand this, that tapentadol as such, when we give, it gives good pain relief, but cumulative cost is very high. And tramadol we are using, everyone is using since last many days, and with the evidence last week lecture, I think if somebody has heard, hardly there are any evidence of using tramadol also for a long time, and for pain management. And for chronic pain, there are no evidence at all. For cancer pain, I think, although there are not, even the meta-analysis and Cochrane review said that there are not great evidence of using tramadol for cancer pain also last week lecture by Alice. But you know, in the villages and in the district level of various parts of the country, morphine is not available. So we will continue to use this, but definitely if dextropropoxyphene will be available, it will be the best, because it is cheaper and it is effective also. Because the old people, we remember that we used to use this a lot, and it used to work very well. So try this if it is available in the market in your places. And second line medication may, I think dextropropoxyphene will be the best for, it's like it is no, again the evidence is best on this side on dextropropoxyphene. And with last lecture, it was an eye opener for everyone that there are hardly any evidence of using tramadol for any sorts of pain. So it's not that we will stop using tramadol because of the last lecture, but again, this is the purpose of these lectures, that we will see a lot of evidence, and we will have a latest update on medications. So thank you, Dr. Mayur and Dr. Bhavna, and thank you everyone, Vidya, Dr. Jennifer, Dr. Reena, for adding your experience in this lecture. Dr. Preeti, Dr. Stanley, you want to say? Yes, please go ahead.
Just to emphasize, based on the last lecture, depending too much on tramadol, we need to, put our efforts to make morphine available everywhere, so that we can go on to, low dose morphine rather than struggling with all these this thing, and to go on to a, more costlier drug like tapentadol, So I think second, low dose morphine is something that we should always keep in mind.
Absolutely, Dr. Stanley. The last lecture was so good. It was so fantastic, and systematically all the evidence she has brought with all the years and latest evidence of 2021, it was such an eye-opener that there is hardly any role of tramadol. So it is better that all of us should start using low dose of morphine in moderate. Yes, Neetu, go ahead.
Ma'am, I wanted to add one more point, that everybody was comparing tramadol with tapentadol, that tapentadol is much more costlier. Yes, I agree to that, even though I have no personal experience comparing tramadol with tapentadol, but theoretically, I want to emphasize that tramadol is actually a prodrug. It needs activation by enzymes and all. But tapentadol itself is an active drug, and there is no need for activation using enzymes, and also there are less interaction with the CY, that family of enzymes, and eventually there are less side effects actually. Also, serotonin syndrome and all are found to be less with tapentadol, and it is more strong and everything, and it is much efficacious compared to tramadol. but the cost, of course, tapentadol is more. But actually, it is proven that tapentadol is much better than tramadol.
Okay, thank you, Neetu. I think again, all these are theoretical, the explanation. We should use it and see that, and we should be waiting for the more evidence of using tapentadol versus tramadol. So maybe if we can pick up, somebody can pick up this study from India, and I think this will be a great contribution. And low doses, already a study is going on at AIIMS, the low doses of morphine versus tramadol. So already there are evidence that low dose of morphine is much better than using tramadol, and it's like unnecessary giving side effects to a patient. We will see that what evidence will come in future. But till the time, I think with last lecture and today's lecture, we can conclude that second line medication, tapentadol, using all these medication, it is much better to use low dose of morphine because there are so many side effect profile of these medication. And if at all we can use, and the new young generation, if you want to use dextropropoxyphene is a good analgesic, and try to use it. It is officially, it is now available for cancer pain management, but I am not sure that whether it is available in the market in the pharmaceutical company or not. So thank you very much, Bhavna and Dr. Bhavna and Dr. Mayur. Dr. Preeti, if you want to say in their introduction, because I was not hearing your sound, if you want to say something about you want to praise these two young people, Dr. Bhavna and Mayur. Dr. Preeti?
Yes, thank you, madam. Mayur Mayur will be our first palliative care specialist at Gujarat. He is confident, he is punctual, he is determined. His thesis topic is comparison of methadone and morphine. As people were saying, methadone is the second line of drug. We took this as a dissertation, compare all aspects of morphine and methadone. Bhavna is also sincere, hardworking, and she's team player. Actually, I would say Bhavna has taken up the responsibility of department, as I have been given another responsibility of administration. I am also thankful to my second year resident, as Mayur is exam going student, and his exam is from the 1st April. So Dr. Lekha and Dr. Varun has prepared all PPT for both the candidate Kikato and for the Mayur. So thank you. I am very much thankful to my department. They are all supportive, and I can see Mayur will be the team leader at his city. Thank you, everyone.
Okay, thank you very much. So we are 5 minutes before time, and I think it's good because early morning, everybody will have to go home for their job. And thank you very much, and see you next week with another topic. And we will start, please join before 6:30 because we will start sharp at 6:30. Thanks a lot. Thank you everyone for sharing your experience and giving input. Thanks a lot, and have a nice week.